So very good morning to everybody here at the Forensic Department in RSCM, as well as at Pullman Hotel, and for everybody who's actually joining us this morning. So very good morning. I would like to thank the organizers for putting together this conference and for the kind invitation. So this morning I will speak for about 20 minutes on the topic of endoscopic ethmoid and sphenoid sinus approaches. Forgive me if some of you all have heard this content before, because I have presented some of this previously. Let me just hide this. Can you see the screen?
Yes.
Okay, and the audio is okay?
Yeah, it's okay.
Okay, so what you can see here is basically the ethmoid bone, yeah? So in the sinuses, we have got paired bones and we've got single bones, right? So it's a kind of the symmetry of life in a way, because if you think about cavity, front, at the middle, and at the end, we've got single bones. The frontal bone is single, the ethmoid bone, as you see here, is single, and the sphenoid bone is also a single bone. And then it is paired by two bones on either side, which is the maxilla, and you've also got the palatine bones on either side, yeah? So on this picture here, you can see in the white arrow, so this is actually the posterior nasal septum, yeah? So this, remember, is one bone. There are no two ethmoid bones, there's only one. And this is the midline. This is the perpendicular plate of the ethmoid, which forms the posterior septum. And on either side, in the black arrow you see here, is actually the middle turbinate. And all of this is actually the ethmoid air cells. And the lateral limit of this is the lamina paparicea, which is the medial orbital wall. And superiorly here is actually the anterior cranial fossa. So this is what would form the olfactory groove, where cranial nerve number 1 sits, and in the midline.
Recording in progress.
Yeah. So it's important to understand the structure of the anatomy from the bone point of view. And when we put that together with the frontal bone, then you get a better perspective of what we're dealing with during surgery. So you can see here, this is the cranial view of the anterior cranial fossa. That's the crista galli. And you can see all the cribriform plate holes where the fibers of the first cranial nerve pass through. The olfactory bulb will sit here, and the fibers will pass through the foramina into the anterior nasal cavity. And here you have all the features of the intranasal component of the ethmoid bone. So I want to emphasize one thing by looking at the CT scans, all right? So on the CT scan, you have the same view here, all right? And if we superimpose the ethmoid bone over the CT scan, this is what basically it looks like. So you have the same features here. This is the olfactory groove, the crista galli, and this is the ethmoid groove. Now, one thing to note, where you see this thick red line, that is actually exactly where the frontal bone actually overlaps on the ethmoid bone. So when we do surgery, you're not going to get a CSF leak where there's the thick frontal bone lying laterally. You will get a CSF leak where the ethmoid bone is not protected by the frontal bone superiorly. So that's generally at the lateral lamella of the cribriform plate and the medial part of the ethmoid roof. So this is the area where you have to be very careful. Laterally, you are generally protected by the thick bone of the frontal. So you won't get as much of an issue with CSF leak. So here again, you see this picture. So this is the orbital plate of the frontal bone, and it extends medially over the roof of the ethmoid, partially. And the medial part is exposed, and these are the eggshell thin parts of the cribriform plate. So this is where we have to be very careful when you are doing ethmoid surgery, especially when you're going superiorly, yeah? So we will talk about it more when you're doing the dissection later. So this white area here covers the entire ethmoid. So for the junior residents who are listening in, generally we divide the ethmoids into the anterior and the posterior ethmoids, and the frontal right at the anterior part and the sphenoid at the back. So I will generally, if I show you my personal approach and sequence for doing FES, after finishing the uncinectomy and the middle meatal antrostomy, I will usually keep the intact bulla and find the location of the anterior frontal. Now, this is not to widen it very completely, but actually just to identify the location of the frontal, and then proceed to do the ethmoid bullectomy, or what we call the anterior ethmoidectomy, keeping the superior half intact. Why? Because the superiorly is where you run into trouble. You want to orientate yourself completely before you complete the job. And after completing the anterior ethmoidectomy, you need to turn all your instruments medially and go and identify the sphenoid sinus first, and then come back and complete the posterior ethmoid. Finally, complete the frontal and widen the frontal. Now, the reason for apparently jumping from the anterior ethmoid to the sphenoid and then the posterior ethmoid is because the most dangerous place to be is actually in the posterior ethmoid. The reason for this is because the medial rectus is very close to you. Remember, the orbits are coming from a lateral to medial direction. The landmarks tend to be a little more difficult to identify. You're deeper in a pocket, there's bleeding, it's difficult to identify landmarks. It's much safer to go medially, identify the sphenoid, and then come forwards again. Now, the other point about identifying the sphenoid early in your surgery is, remember, when you're operating using the endoscope, it is a two-dimensional device. It does not give you depth. You will not be able to identify depth unless you're using the proprioception of your instruments. So once you identify the sphenoid, you already have your posterior wall. The other thing you'll find in your sphenoid, once you widen it superiorly, is your planum sphenoidale, which is actually the roof of the sphenoid. So once you have created the back of the box and the roof of the box, then it becomes a simple job to complete it anteriorly. If you do not have that depth perspective early on, you become disorientated, and that is the number one reason for complications during sinus surgery. Yeah. So remember that during sinus surgery, especially with the endoscope, you want to remain orientated as much as possible. Disorientation is the number one cause for complications, right? So yeah, so now let's go into the sphenoid sinus. I'm sorry about this thing that keeps popping up. Let me see if I can get rid of it. Okay, so this is the anterior view of the sphenoid sinus. I'm sure a lot of you all have seen this picture before. So we divide the sphenoid into several parts. In the center here, you have the body, which is where the sphenoid sinus is located. This is the right sphenoid sinus. You can see the ostium for the left sphenoid sinus. This is the intersphenoid septation, and this is the rostrum. Later on during the dissection, when I remove the mucosa overlying the rostrum during the rescue flap, you will see that this area becomes exposed, which allows you wide access to the body. So the other parts is the lesser wing, the greater wing, between which is the superior orbital fissure where cranial nerves 3, 4, and 6 pass through. You've got the pterygoid root, which is the pterygoid process here. And further inferiorly is the medial plate and the lateral plate of the pterygoid process. And very importantly, medially here is the Vidian canal, which transmits the Vidian nerve and the neurovascular bundle. And slightly laterally is the foramen rotundum. Okay. Now, when we flip the bone superiorly, what you can see right at the top is actually the sphenoid, the planum sphenoidale, which is actually the roof of the sphenoid. And then subsequently, what you see here is actually the pituitary fossa or the hypophyseal fossa. And in the middle, you'll find the optic canals, which actually emerge with the optic nerve. And in the middle of the hypophyseal fossa and the planum sphenoidale is the prechiasmatic sulcus, which is where there's an angulation and turn from the horizontal planum to the vertical hypophyseal fossa. And from an endoscopic view, basically we call that the transtubercular area. Now, it's important to actually identify the presence of an Onodi cell within the sphenoid sinus. So you can see here on the sagittal view. So this is actually the coronal view first. So how do you know there's an Onodi cell? So on a coronal view, what you want to see is this horizontal septation with a separate compartment superiorly and inferiorly. And this tells you that maybe there's an Onodi cell, or what we call a sphenoethmoidal cell. And the reason why we keep talking about that is because the actual sphenoid sinus gets displaced inferiorly. And now your important critical structures are related to this Onodi cell, namely the optic canal and the internal carotid artery, which is here. So if you do not identify this on your pre-op scan, then you may run into problems during surgery. So you always want to confirm it on a sagittal scan, and you can see here that there's a septation above the sphenoid, and the sphenoid has been pushed downwards. So if you come from a place where you don't have reconstruction of the scans in 3 planes, you can actually get software online, one of which is actually the Radiant DICOM viewer. You can actually purchase it. I don't have shares in the company, but you can get it. And you can put your CD inside and it converts it into 3 planes as long as your coronal cuts have got enough sub-millimeter cuts. Yeah, so that's an important point. Now, I need to emphasize certain vascular problems that you may run into during this kind of surgeries, right? So if we look at the cadaveric dissection in a sagittal plane, there are three main vessels you got to look out for. Anteriorly will be the anterior ethmoidal artery. And behind that, just in front of the anterior wall of the sphenoid will be the posterior ethmoid. And what comes into play during a sphenoidotomy is actually the posterior septal branch of the sphenopalatine artery. Yeah? So the anterior ethmoidal may not directly come into play unless you are doing a full house fest and you're coming from back to front where you may hit it here. So it's also important to look at CT scans to make sure that the anterior ethmoidal is not hanging down on a mesentery. So usually it is right directly on the skull base, but sometimes it gets suspended below the skull base, and that's where it can get hit. Posterior ethmoid is absent in 40 to 50% of cases, all right, depending on which publications you look at. It is not always present, but it may be present, and you need to look out for it if you're going to extend the sphenoidotomy superiorly. Now, this branch is very important, right? So if you just take the mucosa and the bone and extend the sphenoidotomy inferiorly, you are sure to hit it 100% of the time, all right? So the way to do it is to remove the mucosa with the periosteum and mobilize all of that together. And I'll demonstrate that during the dissection later during the rescue flap. So this vessel will move away with the mucosa so you can get a wide approach and not hit this artery. Okay, so these are the branches of the sphenopalatine or the what do you call the internal maxillary artery. And the main branch in play during a sphenoidotomy is this sphenopalatine artery and the posterior septal branch of it. If you make the maxillary exposure very big, like we did in the cadaver dissection yesterday, if you extend it posteriorly all the way, there is a chance of hitting this very big vessel, the descending palatine artery, so just be careful. Yeah? So let's look at the endoscopic view, all right, within the sphenoid sinus. So right at the top again, so it's always good to repeat, right? So this is the third time I'm mentioning the plenum. So right at the top is actually the roof of the sphenoid sinus. So this is the plenum. And then that plenum is actually horizontal, yeah? So the sella is basically vertical, and there's a turn and angulation of about 90 degrees here at the tuberculum sellae, yeah? All right, so that's the one that lies in the middle. And inferiorly, a very, very useful landmark, especially when you're doing pituitary surgery, is the clival recess, right? Because it is the midline, you're away from the carotids, and you're away from any major danger areas. So it's always important to identify the clival recess to orientate you during, especially during skull-base surgery, yeah? So the optic nerve and the internal carotid artery on both sides, and in between you'll have what we call the pneumatized optic strut, which divides the OCR, divides the ICA from the optic nerve, yeah? All right, so these are important landmarks to identify during sphenoid sinus surgery, okay? Now, the other thing you notice here is that there's two lines here, which have actually been drilled down. And this is actually the intersphenoid septation. So when you are dealing with these septations, especially when it is getting in your way, take note, all right? Especially the medial one in this side, it will usually attach to the carotid canal. So if you use any instruments that twists, use a Blixley that twists, there is a chance that you can rupture the carotid artery, all right? So usually what I do is I use a through-cut forceps more anteriorly, and if it's very close and we need to bring this down, then we use a drill. And we use a drill very gently because even a drill can cause holes in the carotid artery, yeah? So this is a summary of the indications for sphenoidotomy, often done for inflammatory disease like CRS, sometimes fungal sinusitis. We do it also for nasal tumors, mucoceles, repair of CSF leaks. And remember that we also do a sphenoidotomy routinely for endoscopic skull-base surgery, especially for pituitaries or anything else, yeah? So we need to master this approach so that you can attack the other diseases beyond that, right? So let me summarize for you all how I think about surgical approaches to sphenoid sinus. Is either medial or lateral approaches. Okay, when you talk about medial approaches, there are common approaches, not so common approaches. The common ones are the transnasal corridor as well as the transethmoid corridor. So examples of indications for this would be isolated sphenoid disease for the medial approach, and for the lateral approach is when you're doing a full house fest. For those of you who don't understand what full house fest is, it means clearing all the sinus disease across all the various sinuses, especially in systemic disease like chronic rhinosinusitis, yeah? So less commonly, the medial approach, we do a transeptal. Okay, that means we raise it up like a septoplasty, go submucoperitoneal, periosteal. This was traditionally used by a lot of neurosurgeons to actually do hypophysectomy or pituitary surgery. So this is not done so much today. And the lateral approach is actually not so commonly done, but the transpterygoid approach. So an example here would be, can you see the CSF leak here? There's a defect in the lateral skull base wall here, and that's caused a bit of herniation of brain tissue. So we would use what we call a transpterygoid approach for that, yeah? All right, so let's get back to basics, yeah? So whichever approach you use for the sphenoid sinus, always remember that we want to enlarge the natural ostium. So we can learn from our learnings from the inferior meatal antrostomy many years ago, where it didn't work until we did middle meatal antrostomy because of mucociliary clearance, right? So we want to actually emphasize the F in FES, which is functional. So we want to widen the natural ostium, all right? So I'll come back to that point later when we talk about the bulges parallelogram, yeah? So the lateral approach, trans-ethmoid corridor, this would be the sequence generally, uncinectomy, anterior ethmoidectomy. Now, do you go to the basal lamella, identify the superior turbinate and sphenoid sinus? Yes, I hope so. Because after doing the anterior ethmoidectomy, as I will demonstrate later in the cadaver, we identify the basal lamella, and then you want to identify the superior turbinate. This is a key landmark for you to stay safe, yeah? Because you want to come medially away from the orbit and the brain in order to enter the sphenoid sinus. So I'm sure you have seen this picture many times before. These are the lamellas of the sinuses attached to the lateral nasal wall. So after the uncinectomy and the ethmoid bulla, the opening into the posterior ethmoid should be medial. So this is the lateral nasal wall. It should be medial and as low as possible, okay? So this is the posterior third of the basal lamella. This is the middle turbinate, the posterior third, which is horizontal, and then the middle third, which is vertical, right? So you want to make the opening just above the turn, but not too low. If you go too low, you end up destroying the posterior third, then you destabilize the middle turbinate. If you go too high, you end up with the risk of entering the intracranial fossa and you're getting a CSF leak, yeah? So we don't want that to happen. You want to stay low and medial. When you stay low, you're away from the brain. You stay medial, you're away from the orbit, right? So this will keep you safe whether you do 100 cases or 1,000 cases, all right? So go medial first. Identify the sphenoid sinus, identify the roof, identify the posterior wall, orientate yourself, and then come back and complete the posterior ethmoid dissection, okay? So you want to go to the sphenoid, and then identify the roof, identify the posterior wall, and then come back to the posterior ethmoid, yeah? Do not attack the posterior ethmoid at the beginning, because that is one of the major reasons for complications happening. So talking about landmarks, so this is the sphenoid sinus. I think it was mentioned earlier yesterday that if you know roughly where is the roof of the maxillary sinus, if you draw a line posteriorly, you will find the sphenoid sinus. If the roof of the maxillary sinus is here, the sphenoid sinus is not going to be up here. Okay, if you go up there, you're going to get a CSF leak, you're going to get intracranial injury. So you want to stay along the vertical line. So that means you have to identify the roof of the maxillary sinus earlier on. So then you proceed on and find the sphenoid sinus. Now coming back to the point about natural ostium. The issue with the bulges parallelogram is that this is creating an artificial opening into the sphenoid sinus. Yes, you're going to go medial and inferior, but you're creating a separate opening away from the natural ostium. So this, I personally would advise you against it. For one reason, it's away from the natural ostium. Number two, this can be difficult to identify in a real patient because of blood, because of polyps. You are surrounded by potential complications. If you go too lateral, you're going to hit the orbit. If you go superiorly, you're going to go through the intracranial space. So avoid this, identify the superior turbinate, go medially straight away. Stay away from danger at the beginning and then come back and complete the job later, yeah? So this is to summarize the medial approach. Now remember that whether the patient has one sinus surgery or 20 sinus surgeries, there's going to be one constant landmark that will always be there, and that is the choanal arch. The choanal arch will tell you roughly where the sphenoid sinus is, okay? So how do we use that, right? So if you look at this endoscopic photo, this is the right side, this is the superior turbinate here, and this is the choanal arch here. So when you look at the imaging, right? So we look at the CT scans. So you use your suction and you measure the diameter of your suction, all right? So if your suction is 4 millimeters, you put your 4 millimeter suctions and you measure 3 or 4, your opening of the sphenoid sinus has to be within 3 to 4 diameters of your suction. It cannot be anywhere else, all right? Now, if you're way above and beyond, you don't know what's going on, then I usually do what is called a rescue flap to make sure that I got wide exposure of this area. I do not go trans-ethmoid unless the sphenoid sinus opens very easily. I try to go medially as much as possible, yeah? All right, so now I think about medial approach in two ways, either a standard opening or a wide opening. I think standard opening, most of you all are familiar with. It's usually used for bacterial sinusitis. But the problem with the standard opening is that the opening is very small. It may scar and close down. So sometimes I use a wide opening if there's fungal disease, if it's recurrent bacterial sinusitis, for tumors, for skull-based approaches. And this is actually using the rescue flap. Some of you all may have heard this. Some of you all may have not heard this. Let me just summarize what is that. So this is actually based on a publication about now 13 years ago. Basically what it is that is a mini nasoseptal flap. So if you look at picture A, this is the cuts you make to create a nasoseptal flap. In a rescue flap, the only difference is we make a single cut at the level of the sphenoid sinus ostium and bring it forward along the septum. This picture here appears to be a little bit high. Usually I make it a little bit lower because you don't want to damage olfactory function, right? If you go too high and you use diathermy, there's a risk that you may cause smell dysfunction, yeah, okay? So, so you make one cut, and what that allows you to do then is to mobilize all the mucosa down off the septum and off the rostrum, and it gives you a wide approach into the sphenoid sinus. And this is especially helpful when there's problems identifying it, okay? So I'll give you a quick case of a patient who came in with bloody discharge from the nose. Family history of nasopharyngeal carcinoma. So we actually tested her for EBV, which happened to be elevated. So therefore, we then did an MRI scan, which then showed that there was isolated sphenoid sinus disease, yeah, okay? So in this case, it wasn't NPC, but it was sphenoid sinusitis, and it appeared to be fungal, okay, based on the MRI appearances. Why? Because it appears to be dark in T1 and T2 with very severe enhancement of the wall, yeah? So you can actually make this diagnosis on the CT. You can see on the CT very bad hyperostosis on one sinus. When it's asymmetric, very bad hyperostosis, oftentimes is fungal sinusitis, okay? So I'll just show you a quick video of the case. So I think we are overrunning. He's told me my time is up. Okay, so this scan you've already seen. Okay, so this is the beginning of the case. You can see the blood coming down from the sphenoid sinus, okay? So this is the choanal arch, as I was telling you about, all right? So this is the beginning of the case. Usually, I do an in-out fracture of the inferior turbinate. It creates a little bit more space. So this is a direct transnasal approach. So gentle lateralization of the middle turbinate, of the superior turbinate, injection of local anesthesia just above the choanal arch along the rostrum. All right, so this is the choanal arch, so roughly 1.2 to 1.5 cm above. So I use the debrider a lot. So this is actually the cutting instrument, the debrider that is opening the sphenoid sinus ostium. You can use other instruments like a mushroom punch, a curette, to actually make this opening. So now you can see there is fungal disease inside there. So this is a standard sphenoidotomy. So clearly you're not going to be able to solve this problem through that small hole. So then what do we do, right? So this is where the rescue flap actually helps. So what I usually do is use a what we call an arrow tip diathermy. You can see it's like a needle tip diathermy, and it has to be long enough so that you can reach the back of the nose. So we make a horizontal cut at the level of the sphenoid ostium. Do not go high, stay low until you reach the front of the middle turbinate, and then you can angle it upwards. Then you use a cottle dissector to gently dissect the mucosa away from the posterior septum. So you can see you can use a ball probe and go subperiosteal. And you can actually see exactly what you're doing so that you don't puncture a hole through. So what you can see here is that we have now exposed the bone of the rostrum here. And the sphenopalatine artery is inside that mucoperiosteal flap, so it will not bleed, yeah? So then the other trick that you use is to use the suction and park it below the rostrum, and it will fit right there. So that keeps the flap away. Then you put a third instrument inside the nasal cavity on the right side again. So this is actually a mushroom punch that I'm using to widen that opening. And now you can basically remove the entire frontal wall of the sphenoid without causing any major bleeding, okay? So this is a down-biting kerosene. So you notice no drills. You don't need to use a drill for this, okay? You can use cold seal instruments. Then it becomes very quick, very easy to remove all the disease. So there's some pus inside, there was fungal disease inside. So this becomes a very quick and easy procedure, okay? And it allows you to use with an angled endoscope. You can see around, and then we put a bit of packing. Now, that mucosa that we removed can be put back in place, okay? So this is the mucosa that was, so this is actually what we call that rescue flap. It was actually rescuing the pedicle of the nasoseptal flap. So there's a bit of confusion there, yeah? So once you're done, you can actually push it back. And then it looks like we didn't do anything, right? So remember to remedialize the middle turbinate, because if not, you can get lateralization and sphenoid sinusitis. So you see that this cannot scar down. It's very wide. It will not cause a problem. You don't have a big septal perforation. You only have a big opening at the back. And that is what we call a wide sphenoidotomy. So I think, shall we stop here? I have one case of a transfer, but the time is overrunning. We can proceed to the dissection. Yes? Yeah. Dr. Dai, yeah, we proceed. Yeah. Okay.
Thank you, Dr. Soma, for your insightful presentation.